We move on to next speaker. She is Dr. Ishan Goyal. He'll be presenting on a rare case of idiopathic orbital inflammatory syndrome with late response to steroid treatment.
Good evening, everyone. Thank you, AIOC, for this opportunity. My case is a rare case of idiopathic orbital inflammatory syndrome with late response to steroid treatment. Orbital pseudotumor, also known as idiopathic orbital inflammatory syndrome, is a benign, non-infective inflammatory condition of the orbit without identifiable local or systemic causes. It's a diagnosis of exclusion with directed exclusions towards neoplasms, infections, and systemic disorders. It is the clinical history and clinical evaluation are the mainstay of the diagnosis, and orbital MRI is the main important diagnostic test. In our case, a 54-year-old farmer presented with bulging of right eye since 2 to 2.5 months. The proptosis was painful. The pain was dull at rest and sharp on eye movements, and more so looking towards the right side. The restriction of movement on the right side was associated with diplopia, more on the right lateral gaze. The patient went to an ophthalmologist elsewhere and was prescribed tablet estazolamide SRBD for 20 days and timolol eye drops but the patient did not improve symptomatically. The patient was a known case of diabetes since 10 years. There was no documented history of being COVID positive and no features in the history suggestive of any mucormycosis. On inspection of the proptosis, a unilateral axial proptosis was seen with Naviger sign positive and periorbital fullness. On palpation, the skin over the lid was normal. The skin was pinchable over the lid. There was no evidence of raised temperature locally or tenderness or pulsation thrill. There was resistance to retropulsion felt in right eye. Exophthalmometry by ruler method showed right eye axial proptosis of around 4 mm. On extraocular movement examination, partial restriction of movements in all gazes of right eye was seen with maximum restriction on abduction. Diplopia charting showed maximum separation in right lateral gaze. On ocular examination, facial asymmetry was noted with periorbital fullness on the right side. The vision was, the best corrected visual acuity was 6 by 12 parts in right eye and 6/9 in the left eye. This was owing to the cataract itself, cataract in the eye. Conjunctiva was chemosed and congestion was there, and the lid edema was noted. Blood investigations on admission showed raised CRP levels of 6.8 and ESR of 40 mm at the end of 1 hour. The thyroid profile was within normal limits. Blood investigations were repeated after 1 week, where CRP levels were reduced to 3.2 and ESR reduced to 22 mm at the end of 1 hour. ENT reference was done and DNE was done to rule out sinus involvement, any eschar formation, and any mucormycosis. It was unremarkable within normal limits. MRI finding, the patient presented with an MRI done from elsewhere. On admission, the patient which had an MRI showed features concerning for right orbital pseudotumor. The possibility of cellulitis was less likely. As in our case, the patient did not respond to the treatment treatment. MRI was repeated after 1 week. Same, almost similar picture was seen. Inflamed, bulky extraocular muscles were seen, and preseptal compartment with protrusion of right orbit. Possibility of pseudotumor was noted. These are the orbital images showing right eye bulky extraocular muscles. The patient was put on systemic steroids, that is IV methylprednisolone 250 mg QID for 3 days along with broad spectrum antibiotics, and timolol eye drops were started. Patient did not show response to steroid therapy initially. Patient was shifted to oral steroids after 3 days and tapered over a 6-week period under close follow-up. After 2 weeks, the patient spontaneously responded to the treatment with reduction in proptosis from 19 mm to 16 mm and reduction in lid edema, conjunctival chemosis, and improvement of ocular motility. Examination after 8 weeks showed reduction to 16 mm proptosis. The patient is presently in remission. It is a rare condition that poses diagnostic challenges. The most common signs include eye pain, eyelid swelling, and proptosis. Around 75% of the patients have a remarkable improvement after 24 to 48 hours, such that it is called a diagnostic response to steroids. Although most cases have rapid and dramatic response, there is a chronic form with progressive fibrosis associated with mild or poor response. Orbital MRI stays the mainstay of the treatment, while biopsy is usually not performed at presentation. And however, in chronic forms, the patient might show delayed response or mild response to steroids. There are alternative modalities that can be used, like radiotherapy, use of chemotherapeutic agents like cyclophosphamide, methotrexate, and cyclosporine. These are my references. Thank you.
Why did you repeat MRI in 1 week?
Sir, actually, what in our practice, what we say is it will show a diagnostic response to generally to steroids. But even after IV methylprednisolone, that is considered to be a stronger IV set of steroids, it had no reduction in the proptosis, chemosis, and the intraocular pressure. So we were concerned whether we are on the right track or not. And the MRI was done outside, not in our setup. So we wanted to repeat and see if we are missing any septic etiology or anything like what of significance, any mass is there. So we got it repeated from our setup in the in-hospital radiologist and with the reporting done again. So that is why we wanted to know. But since it was similar picture, so we continued with the treatment with oral antibiotics after 2 weeks, which is generally very late for a pseudotumor. We got the response.
You gave the IV methylprednisolone QID.
250 mg, either
Yeah.
1 gram.
You don't give it 1 gram in a infusion drip or something?
Just because it was done in medicine reference, ma'am, because he was a diabetic, they avoided with 1 gram.
They wanted to give it this way.
Yes, yes.
And how many months has it been after he's been in remission?
Now he is around, this is a case, 8-9 months old case, ma'am. So now he is fine, ma'am. He is on a regular follow-up around once in 2 months he comes.
And what will you do if it happens again?
Ma'am, similar steroids.
Similar steroids? Yes. And what if it comes back again? Because this is the biggest problem of
Yes, ma'am.
inflammatory these syndromes, right?
Yes, yes, ma'am.
So you have to have a strategy. ये एक बार में तो बच गए.
Yes.
इसके बाद?
Steroids,
So,
ma'am.
it's not, I mean, like steroids and steroids is not the answer.
Yes, ma'am.
Huh? So you have to have a careful strategy because ultimately you might have to do a biopsy also. You have to consider it, right? And because it's the first episode, maybe you're lucky it may not happen again.
Yes, ma'am.
But recurrences
Yes.
are quite often in these
And
cases.
it is, if it is not recurring, we don't say that it is an intraorbital
Yeah.
orbital inflammatory disease. So you have to rule out, even if it is like IgG4 disease, so you have to do serum
Yeah.
IgG levels.
Systemic workups.
Systemic workup is very important.
Okay.
Thank you so much.